In this video, we'll be covering the placement of the Blakemore tube for significant upper GI bleeding from presumed esophageal varices. Prepare the gastric and esophageal balloon ports by placing a Blakemore port and a 3-way stopcock into each. Ensure the gastric and esophageal balloon are completely deflated by aspirating each port with your syringe. Once you are ready to place the tube, insert the straight tip of the bougie into the most proximal gastric port of the tube. This will help to reinforce the floppy tube and make placement easier. While standing on the left side of the patient, feed the tube and bougie into the oropharynx and advance to approximately 40 centimeters. Ensure the device has not coiled in the posterior oropharynx prior to proceeding. To confirm placement, instill 50 cc's of air into the gastric balloon via a 3-way stopcock. At this point, obtain a confirmatory X-ray to visualize the gastric balloon in the stomach. Once confirmed in appropriate position, instill an additional 250 cc's for a total of 300 cc's of air into the gastric balloon via the 3-way stopcock. Remove the bougie and repeat a chest X-ray to confirm appropriate placement. Once the gastric balloon is inflated and in good position, you'll need to set up a weight to apply continuous tension to the GE junction. Tie one end of your Curlex to the distal end of the Blakemore tube near the ports. Run this over an IV pole and tie the other end to a 1 kilogram weight or 1 liter IV saline bag. Obtain a repeat chest X-ray to confirm placement. Suction can now be connected to the center port to monitor for ongoing bleeding. To inflate the esophageal balloon, connect the IV tubing from the 3-way stopcock of the esophageal balloon port to a handheld pump. Inflate to a measure of 30 millimeters of mercury. Close the stopcock.